classy. But if you needed other terms, that's where they are. Okay. Hopefully y'all all got a chance to at least do part of a spay. The indications that we have are not just to prevent unwanted, but also to help prevent mammary tumors. I mean, we had that in Red Reynolds today, right? How what the reduction is after first heat, second heat, etc. To prevent pyometro, okay? Metritis, inflation, trauma, all that is lesser. So when you want to do the selling points for your clients, the two biggies are mammary tumors, which is the #1 tumor in female dogs, and pyometro. Okay? Hopefully you now know the clip from xiphoid to pubis. Even if you get good at doing that spay through that buttonhole incision, you never know when you're going to drop a stump and have to go after it. So be prepared. In other words, prepare the dog to open them all the way up. And then the midline incision, just cobble to the umbilicus, the middle third. That's after you get used to finding the linea. Until you get good at finding the linea, start at the umbilicus. Okay, start at the umbilicus. You can find it best there. And if you have had problems doing that. You can carry it through the subcutaneous to find the linea. I like to tin it upwards, make a poke hole, put in my thumb forceps as a guide, and use my blade. Some people like to use the scissors. I'm not going to be judgmental. I don't particularly care for scissors. I don't think I can stay on the linea as easily with scissors. If you're good at using an ovariohysterectomy hook, then great. I'm not, so I just make a little bigger opening and pull things back and grab the uterus. But if you're going to use the hook, the way it's supposed to be used is you run it down with the hook towards the body wall, against the body wall till you get to the gutters, turn it around, and then pull it up. And if you're lucky, you have the uterus. Like I said, it never works for me. Confirm that it is the uterus by going and finding the bifurcation. When I was in residency, I had a student actually say, oh, here's the ovary, this is the uterus, and it turned out to be the ureter. Thought was the ovary was a lump of fat right next to the ureter. So always go back, make sure it goes to bifurcation. If it goes to the bladder, it's the ureter, all right? You don't have luck with the...
Yes, you were to, like, if somebody did mess up and ligate, cut one of the ureters, could you just ligate that ureter off and it would drain to the other one just fine, or is that like toast?
Well, you have to remove the kidney too. Do that.
That's right.
You want to try to save it first, so do a resection and anastomosis, and remember from what was done yesterday, Wednesday, when you do that, make it an oblique cut so that you have a nice big opening that's less likely to stricture. Instead of straight, you make it as oblique as possible. If you don't have luck with a hook like me, like I said, all you have to do is look underneath the urinary bladder for the horns of bifurcation. Don't forget that the descending duodenum and the descending colon are your natural retractors for the abdomen. You can use that to pull up and pull all the intestines over it, and you should be able to find it then. And you can go find the suspensory ligament, stretch or break it if you need to. If you don't need to, if you can get that ovary up enough that you can do your ligation, you don't have to worry about the suspension. Okay? Usually that's older females that have had a couple of litters that get stretched out. The young ones you usually do have to. Make a hole in the broad ligament, cobble to the ovarian pedicle, place 2 or 3 Frau or Rochester columns across the pedicle. You guys don't have cryo forceps in your backs, okay? I can't believe how many reports I got. They said they use cryo. Yeah, y'all don't have any. They tend to be really a lot bigger than one. So, do not include the ovarian tissue. My hit for you guys, this is what I do, is I put the ovary in my thumb and forefinger. So I have a complete ovary in my fingers. Then I can place the most distal clamp right up against where I'm holding. And I know I'm not including ovarian tissue. Then when I go to cut that pedicle, I'm cutting on the opposite side of that clamp. If you leave some ovary behind, you can still have pyometra. It's called a stump pyometra. It's been known to be a frustration, okay? Figure 8 or transfixing ligature. Some of you guys like to use the Millers, that's fine. The key is you want to make sure you get all the vessels. If you have a really fatty pedicle, get the light to show through it. And you can highlight or see the vessels a little bit easier that way. Okay? Always do 2. And I like the encircling to go between the transfixing and the body. Okay? I usually put the encircling on first, so when I do the transfixion, if I go through a vessel, it's not going to bleed, just by encircling there. Don't forget about this. This is the body wall. This is how you close it. I think y'all are all getting the idea now. This is the pictures. I've already gone through this once with you guys. When you get down to the uterus, this is what I recommend. And I'm going over this again because I think some people have missed it. See my drawing here? I actually modified this. The little red things are the vessels. If you do a transfixation, just barely grab the uterine wall here, put 2 throws on it, then wrap the end around, and put the rest of your throws on, 4 or 5 throws. You get 2 ligatures. You get a transfixation ligature on this vessel and an encircling on the whole thing. If you do one of those on each side, you've got 4 ligatures with only 2 and 2. And they're very secure. You don't tend to have bleeding. All right. There's your Miller's knot. I'm not a big fan of it. I don't know what the advantage is over a regular one, but some people like it. Okay, you can use 2-aught or 3-aught in most dogs. PDS or monocryl, Maxon, and Biosin or other manufacturers of the same type of suture, okay, or Vicryl. I would recommend using a 2-aught PDS for the body wall closure for most dogs. You start getting pushed 80, 90 pounds, you might want to bump it up to aught, okay? And I say PDS because monocryl loses its strength in 2 weeks. That's barely time for that body wall to heal, all right? They say you can't use monocryl. I just like to sleep at night. You know, I'd rather it stay a little longer and me be sure that the dog's healed than take a chance, okay? Definitely, if you have a patient that you think is going to have prolonged healing or has some medical issues, they might be cushingoid, they may have diabetes, something like that, definitely consider doing the PDS, and sometimes we even put in something that won't ever dissolve, proline or nylon. And I've asked Dr. King if he agrees with me on that one. Okay? Make sure you close the linea or the external rectus sheath in the body wall. You try to avoid to get anything else in there. You might get a little bit of muscle, you might get a little bit of subcute, but you don't purposely try to get those tissues. Because if you have rectus sheath and rectus sheath coming together, and then you've got all this other tissue popping up between it, that's a hole that it won't heal through, and it could be a hole for dehiscence. All right? And then remember this line down here, because there's some folks around this place that think you have more secure incisions with interrupt. There is a paper out there that just proves that. It's all whether you get the right tissue, get enough tissue in your sutures, and you have secure knots. Okay. Now, cesarean section. The goal most of the time in a cesarean section is to remove the fetuses as quickly as possible so you can save them. All right? The indications are actual or potential dystocia. Sometimes we plan these. We know certain breeds have higher tendency to get to have discussion than others. English bulldogs, and some of your toy breeds, like Yorkies, Chihuahuas, okay? Or if they have a small pelvic canal, say the dog had been hit by a car, fractured its pelvis and allowed to heal on its own, and all of a sudden she's become pregnant. She may not have enough room in the birth canal to deliver normally. So you might want to plan a cesarean in that case. Here's the breeds that tend to have problems with this. So you have brachycephalics and small dogs. You want to give them fluids and electrolytes, but this is typically an emergency surgery, so it's not like you're going to be stabilizing them over several days before you go do the surgery. And you can spay them in conjunction, okay? So there's two ways to do it. You either remove the puppies first and then spay them, or you can do what's called an en bloc. En bloc, right there at the bottom. And I'll describe that to you. This is what you're looking at in surgery. Okay, en bloc is not recommended if the fetuses are distressed, brachycephalic, or hypoxic, unless you've got enough people to get them out and revive them right away. So if you got at least one person per 2 puppies, you can still do it en bloc, okay? You just gotta be fast. If you have concern for spillage in the abdomen of abdominal contents, then it's recommended to do it en bloc. Mothering and lactation is not affected by spaying these dogs at the time of your cesarean. And you want to perform as much of the surgical prep before you anesthetize them as possible. And we use minimal drugs. A lot of times we'll just propofol them down without any pre-med. You can always give them the pain medication after the puppies are out. Because that, whatever you give mom, the puppies are going to get too. All right? So if in an en bloc, what you're going to do is exteriorize the uterus. You're going to make your windows for your clamps. You're going to place all your clamps, cut, and hand the uterus off. Almost that fast. Then you're going to go do the ligatures. Okay? So you need extra clamps when you're going to do it en bloc. Let's see. If you're going to remove the puppies from the uterus, you're going to make an incision. You can either make an incision in each uterine horn or down at the bifurcation, and you're going to milk the puppies, the closest ones to the incisions, and remove them first. Put a clamp on the umbilicus and hand them off to an unscrubbed assistant for revival. Not religious revival, but reviving the puppies. You can give oxytocin to the dam to help encourage contraction and shrinkage of the uterus. After you have all the puppies out, you close the uterine incision, and then usually you're talking about 3-aught or 4-aught absorbable, and either a single layer or you can do a double inverting layer, okay, just like a urinary bladder. All right, hand it inside. So like I said before, en bloc, you sterilize, isolate, make your windows, milk any fetuses from the vagina back into the uterus. Put your clamps, cut, and immediately hand them off to somebody. And they should have instruments to get into the uterus and get the puppies out. So you really want this to happen in less than 60 seconds, so a minute. If it's your first one, I don't recommend you doing it. Struggling with somebody else that's done one before, okay? Once you get kind of the feel for it, it's not really that hard. The scariest part is, oh my God, I'm cutting this before I ligate anything. Right? Now, to resuscitate puppies. You want to gently suction the nares and the oral pharynx, okay? They used to talk about slinging puppies. We don't do that anymore. They can get brain trauma just like we can. You can gently rock them just a little bit to help the fluid come out, but you don't want to sling them like people used to. You want to briskly rub them and warm them up, and If you've given them the any opioids, you can reverse it with naloxone under the tongue. You can get doxapram under the tongue to help stimulate respiration. And the other thing you can do is acupuncture pressure point. You take a 25 gauge needle right here in the philtrum, between the nose and the mouth, right in the middle. Insert that needle till you hit bone and then twirl it. And it works. It's amazing. Then you're going to ligate, transect, and disinfect the umbilical cord. Inspect each puppy for any congenital abnormalities, and then keep them in a warm environment until mom is fully awake. Okay, you don't want to put them in with her while she's still anesthetized, because she could roll over on them and crush them. Okay. You do want to encourage early nursing, because just like in our large animals, these dogs need the colostrum. Yeah.
When you're making the cut on the, are
You
you
do-
making the cut on the uterine body or on the uterine horn?
You can do either one. If you do it on the body, if you got puppies in both horns, you'll have to make two. Or you can make it on the body and milk them down. I've seen pregnancies where they've only had puppies in one horn. So, it just depends on what you got, how big it is, how much you want to suture, etc. All right, uterine neoplasia is very rare in the dog, less than 0.5%, okay? It's even less common in the cat with 2.9. So if you get in clinics and we have a radiograph of big and large uterus, don't immediately jump on this one. More likely to be pyometra than it is neoplasia, okay? More common in the cat than other reproductive tumors, but that's still pretty rare, okay? And let's see. Usually you can have concurrent pathologic conditions such as cystic ovaries, cystic endometrial hyperplasia, pyometra, indicating there's a hormonal part to this, okay? Don't forget about German Shepherds with the renal cystadenomas and not nodular dermofibrosis. I don't know if that's an Natalie question or not, but I think y'all should have that in your brain, okay? I've never seen one of these, but popped up in both the renal and the reproduction chapters, so it's out there. If you do have a uterine tumor, it's probably a leiomyosarcoma, okay? That's the most common, then after that's adenocarcinoma. Okay. Multicentric adenocarcinoma has been reported, and these things tend not to spread. If you do diagnosis, there's usually metastasis at the time of diagnosis. And this is where they like to go, okay? Pyometra, this is definitely going to be on that one, okay? It's a life-threatening condition associated with it's Friday, I can't talk. Cystic endometrial hyperplasia, okay? When they go into heat, and they're not bred, 4 to 8 weeks later, they end up with pyometra because of this. Progesterone's involved, and drainage is hindered by usually the cervix, but you can't have an open pyo. Cats don't tend to have pyometra. I asked Dr. King if he had ever seen one, he said no. So, probably because they're reflex ovulators. They don't go out of heat till they're bred. And usually when they're bred, they get pregnant. Usually you're talking about E. coli is the biggest offender for the infection. And like I said, you can have it open or closed. And that depends on if the cervix is open or closed. Usually the open ones don't get near as sick. Okay? Look at everything this does to this dog. Hypoglycemia, renal and hepatic dysfunction, so azotemia, you have elevated liver enzymes, anemia, you could have cardiac abnormalities. They get so bad that they go into SIRS, which is systemic inflammatory response syndrome, and DIC. death is coming or dog in cooler. Fossum does a good job of explaining why all these things happen, okay? I didn't want to make it a lengthy topic in lecture, so what I do is I recommend that you go read it. You're probably like me, you'll read it, understand it, and then you'll forget it. So that's why I don't include it on the slide. But if you want to know how all these abnormalities happen with PIO, go read it, and I recommend you go and read it right before NAPLA as well. Now I've got some of them short description here on what happens. So obviously I'm not going to test you on the pathophysiology of all those abnormalities, okay? I do want you to know that it's 4 to 8 weeks after estrus. They may have a discharge, they may have abdominal distension, fever, vomiting, diarrhea, PUPD. You hear all that in an intact female, you should think pyometra first, okay? Medical treatment, only in stable and highly valued breeding animals. We don't recommend keeping these dogs intact because there's a 20% risk of reoccurrence. All right? I give you how to treat that medically, but I'm not going to test you on that, and I'm not going to go over that. But this is what they can look like. The ones I've had actually were worse. All right. An episiotomy. This is an incision into the vulvar orifice to gain better access to the vestibule, the vagina, because of maybe there's a puppy stuck, maybe there's a tumor in there, maybe there's trauma in there that you need to address. It's just like what they do in women for childbirth. You cut it, and then when you sew it up, you sew the mucosal side, and then you suture the skin side. Pretty simple. Now I've had to do a few of these. Epesioplasty or vulvoplasty. It's reconstruction to remove excess skin folds around the vulva. People call this hooded vulva, and they'll have a tendency to get urinary tract infections and vaginitis. So what you do is you just make a crescent-shaped cut into the skin and the fat, take that crescent out, and then suture it together. You should treat the dermatitis and recurrent UTIs as well, right before surgery. And this is actually one of the senior's dogs. This is one of the, and you look at her now, you can't even tell. There was an incision there. Oh, go back. If you ever try to do one of these, what I recommend is you remember divide and conquer. Don't do this in a continuous, at least the sub-Q sutures don't do in continuous fashion. I put one in the middle, then one in the middle here, one in the middle here, and then keep dividing it. Because if you start on one end and go to the other, you might get her crooked. You might get her something up, you know. So if you divide it up like that, you're likely to stay symmetrical. All right. But vaginal prolapse, hyperplasia, and tumor, all three of these tend to get confused. Hyperplasia or hypertrophy occurs during proestrus and estrus. It's not true hyperplasia, but it's edema, okay? A true prolapse can occur with hyperestrogenism or weakness of the vaginal connective tissue. So you gotta sort these out. May look large, usually it's small and can be stalk-like or involve the entire floor. Prolapse promotes straining, okay? You can end up with strangury, hematuria, or tenesmus because urinary tract and anal tract empty right here at the same location. You may actually have a prolapse in the urinary bladder along with it, okay? And this is another thing that can reoccur. So, another good reason to recommend spaying. Typically happens in young, large breed dogs in their first 3 estrus cycles. So, young dog, intact, large breed. If it's not circumferential, vaginal prolapse will spontaneously resolve when they go out of heat. Okay? And you can shorten it by giving GRN or HCG. Again, these dogs should not be bred because they tend to have recurrence. And the tumors, if you think it's a tumor, it's probably transmissional venereal tumor. And you can treat that with vincristine or local excision radiation and immunotherapy. They usually regress on their own, because especially if they get traumatized, because then they'll release the virus from the tissue and they auto-immunize themselves. Okay? Spaying is recommended treatment for vaginal prolapse and hyperplasia as well. Okay? Mm-hmm. Depends on which one you're talking about. We're talking about all three here, these together. Okay? Prolapse, you can sometimes get those reduced without surgery. Still recommended to do a spay. Sometimes you have to do a spay to get them reduced. You have to pull them from the inside. Hyperplasia, same thing. Tumor, that's the only one that's separate from the spay. Because that's usually TBT. It can be a leiomyosarcoma too, though. But then you would recommend spay. And let's see here. We actually had one of these last year, and that's the picture from the book, and I can't tell what's what. That's actually vaginal prolapse. As you can see all the vessels in there. Oh, did I not put that picture in there? Yeah, I did. Okay. Yeah.
Can you do these like cows and do warm water and salt?
Yes. Yes. Salt or sugar, cold, not warm water, cold.
Yeah, cold.
Yeah. That's how we treated the one that is gonna get ready to come off of the picture.
Okay.
So uterine prolapse is just like vaginal prolapse gone a little further.
Mm-hmm.
All right, and it's protrusion of the uterus through the cervix into the vagina. Okay, usually associated with near parturition. The tissue here is donut shaped and becomes discolored. You can have hemorrhage. They can get shocky. Usually they're pretty stable though. Medical management alone, as it says, rarely successful, but we got this dog to reduce before surgery. So right there is dextrose, saline sugar. Lubricate with water-soluble gel, manually replace. You can also give them oxytocin and help with that. And this is a very good example of what they look like. Okay. Be careful. Make sure you know where the urethra is emptying out. Okay. Especially if you're thinking about amputating these, this is another way you can treat them. You just cut around and resuture it back. But if you get the urethra, you're going to have big problems. Okay? I'd probably not do that myself. I'd probably do the spay, reduce them as much as I could on the exterior before surgery, and then take them in the spay and pull the rest back into the abdomen. Mm-hmm.
Is there a way to somewhat tack the stump, I guess uterine stump, up towards the abdomen? Like after you do this bite?
Actually, I have that right here. May require hysteropexy, cystopexy, and/or colonopexy to prevent recurrence. So you're right. Just think about it as a female version of perineal hernia. It's not quite the same thing, but it's very similar. Okay, they're both hormonally related, and you can have reoccurrence, and you can do pexies to help prevent reoccurrence. Okay, mastectomy. You can do just a mass removal, which is a lumpectomy. A simple mastectomy, which is just removal of that entire gland. That's what we did on the dog that was in Grand Rounds today. We did a simple mastectomy on that one gland. You can do a regional mastectomy, that gland and the glands cranial and caudal to it, or complete entire chain, or bilateral entire chain. I don't recommend doing a complete bilateral in one surgery. You end up with too much tension on your incisions, and it's very painful for the dog. Complete bilateral results, well, I already said that. OHE should be done prior to the mastectomy, okay? Because you don't want to seed the abdomen with tumors unless the tumor crosses the midline, in which case the tumor can be removed. Then you want to change out your gloves and instruments, just like, consider it like contamination, so you don't seed the abdomen with tumor cells. There's a little dog with a big memory mass. It is the #1 cancer in female dogs, just like us, and it can be very bad. So this is just showing you a regional mastectomy. We go down to the external rectus sheath, and sometimes you have to remove that external rectus sheath part of it to get clean margins. And then you have to close it, the rectus sheath back to each other, okay? If you do that, otherwise you're gonna have to do this. 35 to 50% of them are malignant in dogs. If you're a cat, it's even worse, 90%. That's been known to be a test question, okay? Going back to the lumpectomy, simple mastectomy, regional, etc., studies have shown that you don't have a difference in cure rates between those. So we've kind of gotten away from doing complete chain mastectomies, because they're all involved. If you get good margins, you can do just a lumpectomy. Okay? If you think it's a bad player, like that one that she talked on this morning, Jasmine talked on, we thought it was a bad player. We thought it was osteosarcoma, so we went wide and deep. Okay. It's nice not to have to do that, because then you know when you go wide and deep, you got to deal with tension. She mentioned this and ran around today as well. If you spay before the first heat, you reduce their risk down to 0.05%. After the first heat, 8%, then after the second, 26%, and it pretty much stays there the whole time. Okay? Cats spayed before the first estrus have a 91% reduction in the risk of developing. This has been a test question in the past. I don't like writing test questions, so I tend to repeat them, okay? The ones you got today, I think there were 2 new ones out of the 7, okay? So you might want to remember these numbers here. Estrogen progesterone receptors are found in most of these tumors. That's why you have the benefit of spaying. Dogs with benign tumors have a more than 3-fold chance of developing a malignant tumor as well. Okay? And this is the kinds you have: mixed tumors, fibroadenomatous, adenomatous, or benign mesenchymal. The really bad ones, carcinomas and sarcomas, tend to be fewer. And here you go, Kayla. Inflammatory carcinomas are the worst ones. Okay? That's because they grow rapidly, they invade the cutaneous lymphatics. When you see them, they look like they have mastitis. In fact, I had one referred to me in residency as a mastitis. They have marked edema, inflammation, red, angry. They're poorly demarcated. They're usually ulcerated. They're bad, really, really bad. So that's been known to be a test question too, guys. Inflammatory carcinomas. In fact, it's on the surgery rotation list. In cats, 90% of them are adenocarcinomas, and they're bad. 91% malignant, right? Tend to be not well circumscribed, firm, often ulcerated. You gotta differentiate them between that and hyperplasia. So still take them off and send them off to the pathologist. Okay. Local reoccurrence is common after surgery, and cats with malignant mammary tumors generally survive less than a year. Here's another thing I wish I had gotten Jasmine to put into her presentation. Any lump or bump you remove, paint the surgical margins before you cut anything else. As soon as you cut it out, hey, set it aside, let it dry a little bit so you can paint it, let the paint stick, and then blood log pick. If somebody wants to get impression smears, have them go through the skin side, not your surgical margin side. Because you put the paint on your surgical margins, and you ask the pathologist, do I have clean margins? And they'll go look at that cut edge and see if they see any tumor cells there. Y'all follow me?
How does the paint stick once you put it in formalin?
It does. Some of it comes off, but enough sticks that they can, and the pathologists love it. They're like, we're so glad you paint margins. Some people go crazy and they paint 3 or 4 different colors. You know, cranial margin, caudal margin, deep margin. At most, I'll do 2 colors. I'll do my edge and I'll do my deep. I'm thinking, because when I close it, it's coming together like this. So if this one's dirty, I'm going to be taking some of this too. So I want to know, do I need to go deeper, or do I need to go wider, or both? So. Okay, orchidectomy. This is neutering male dogs, all right? Please convince owners to neuter their male dogs. It's not just for preventing pregnancy, okay? It'll also reduce their chances of running the neighborhood, looking for females. It'll reduce their chances of getting hit by cars because they're not running the neighborhood. It'll reduce the number of fights they get into. It will reduce the amount of peeing they do inside your house, okay? It also prevents a whole bunch of diseases I've already told you about. Prostatic diseases, perioral adenomas, perineal hernias, testicular cancer, trauma, all kinds of things. And if they end up with an endocrine disease, especially diabetes and, I won't say Cushing's, they do better if you move them, right? Can be done pre-scrotal or perineal, and I don't know why those people down in Houston used to do them scrotal. I don't recommend that, okay, unless you're doing an ablation. That's real delicate tissue. Number one, it's real thin, it's hard to suture, and it wants to bleed like crazy. Because the function of the scrotum is to keep those testicles cool or warm, depending on the ambient temperature, for sperm production.
What if you don't suture it and you put tissue on it? I'm just asking.
Okay, I'm a boarded surgeon. I never heard of that or seen it until I came here and people went to bark. Okay, I'm like, what are you doing? So obviously it's not in FOSSA. It's not in any other surgery book I know of. So don't do it. I mean, what's the benefit of doing it? Now, if you're doing an ablation, yes. Because you're taking the scrotum off, okay? So, now you can do them open or closed, okay? And that's referring to whether or not you open the vaginal tunic. And for those of you who had scrotal hematomas, I'm not exactly sure why, but I think it's because you have the testicle, okay, and it's got a connection between it and the vaginal tunic, and then the vaginal tunic's got a connection between it and the scrotum. As that whole system has to pull that testicle down when they descend, right? Those connections also have blood supply to them. I've seen scrotal hematomas with them open or closed castration. You usually don't see it in puppies, you usually see it in older dogs. So I think what's happening is when you tear either that tunic from the scrotum or the testicle from the tunic, you're causing bleeding.
So, in terms of age, will you do like after 1 year old, do a thorough ablation, and before that, just preschool?
I would recommend that, unless it's a little tiny dog, a toy breed. But yeah, I would recommend that, because then you're not going to have a hematoma. So if you don't want to do a scrotal ablation, I would recommend you put a clamp on that before you tear it, and leave the clamp on the part that's staying in while you're doing the rest of the neuter. Just clamping it for a few minutes might fix that. But I've had them too, so it's not you guys, all right? It's not you guys. The first one I had was on a veterinary technician that adopted a dog at our stray facility. So I felt really bad. But he lived a long, long life, so he was all right. I think y'all know how to do this. I've already been over it when we did the lab. Y'all haven't done any cats? When we do cats, this is what I do. You take a hemostat and you flip it over, and then you reach around and grab this end, and you cut it off, and then slide it off. You gotta go in the right direction. When you get into clinics, ask me, I'll show you. I take a surgical mask and I do it with the strings, okay? So,
There's a wrong direction. I've
Yeah.
always done them like.
well,
either
if
as long
you,
as I get my, the knot.
if you go this way and you grab that side, you won't have a knot. It'll just slide right off.
Oh, I see.
So it's one of those things that you kinda gotta do, and go, okay, now I get it. You know, you can also just ligate it. You can just throw suture on it if you want to. Yeah, yeah, people say that adds $10 to the cost of the neuter. So, I actually think cat neuters are fun. Be careful when you pull the cat testicle out though. I have seen it. My very last surgery of my residency was to go into the abdomen on a male cat that had been neutered, and they pulled so hard it ruptured his testicular artery halfway between where it came off the abdominal aorta and the inguinal ring.
So, shelter life, of course, but I've seen it done to where they literally are just ripping them out. There's no ligation,
I don't recommend that.
okay.
I mean, as I was walking through the prep room, the doctor said, hey, Dr. Linn, can you come over here and see if you can figure out which of the cords is bleeding? And I was able to fish them out. I said, neither one of them, but you got a lot of blood coming out here. I said, yeah, I can't figure it out. And I grabbed a needle and syringe to do a belly tap, and I got blood. I said, you're bleeding internally. So, I didn't know where it was ruptured, but I found it halfway between, like I said, the abdomen, where it came off the abdominal aorta and the inguinal ring. So, yeah. Yeah,
When you go there and find it, what do you do?
I just ligated it,
Okay.
took the end of the bleeding artery and clamped it in a mosquito and put some suture on it. Okay, scrotal ablations, you wanna do these, now we know older dogs that need to be neutered, okay? Or if they have trauma, neoplasia, abscess, they would not let us neuter working dogs until they had medical reason. Benign prostatic hyperplasia, scrotal trauma was a big one. These guys would get scrotal dermatitis all the time, okay? What you're gonna do is make an elliptical skin incision at the base of the scrotum, being careful not to excise too much skin. And you need hemostasis. Remember I said there's a lot of vessels in the scrotal sac? I make my skin incision and I use cautery the rest of the way. And I cauterize right over the testicle, because if I go too deep, guess what? The testicle's going away. I don't care if I burn it. It's gonna end up with the trash anyway. Then you neuter as usual and you close subcutaneous tissue pretty much like you do a pre-scrotal. You're gonna catch the side, catch the medium wrap, and catch the other side, except it's a lot bigger. So I've drawn a little picture here. This dog is laying on its back, okay? My line is where the scrotal skin changes to more normal skin. It's kind of a gradual transition, but that's about where you want to cut. Make a frowny face on either side, because in the middle is where you're going to have the most tension. And you should be okay without having a close tension. Cryptorchid castration. When an animal's cryptorchid, you definitely have to go in and take care of it, because there's a lot of sequela to cryptorchid, and I'll get to that in a minute. But basically, it's failure of the testicle to descend into the sac. If they're not down there by 2 months of age, you could pretty much call them a cryptorchid. Unilateral is most common. It could be either anywhere from where the ovary sits in a female, all the way to in the inguinal ring, or inguinal canal, or in the subcute. Okay? They're usually small, soft, and misshapen. Congenital absence is rare. And if you see that, it's called monoorganism, or an organism. They think it's a sex link, autosomal recessive traits, so don't breed these guys, they'll have more of them, and it makes them predisposed to neoplasia, seminomas, and serotoli cell tumors are the ones we're talking about. If it's inguinal, you can incise directly over the palpated testicle and remove as previously described, right? If it's abdominal, you're gonna go in just like a spay, all right? How you find it, there's two ways. You can either follow the testicular artery till you come to the testicle, or you can follow the vas deferens coming up from the urinary tract to the testicle, okay? I've heard of people removing prostates that they thought were cryptorchid testicles. How in the heck did that happen? How did you make that mistake? Don't be that person. Don't be that vet. Okay? Once you find them, you're gonna ligate as usual. Okay, you're gonna ligate the testicular artery, and then follow the ductus down to the urethra and remove that as well. Okay? This is actually laparoscopic removal of one. So they put staples across. This is actually the pentaform plexus, and the testicular artery sits in the middle of that, right? And then this is the ductus. When I was in residency, there was an argument one day in rounds, they had resident rounds, and the faculty was arguing back and forth whether you ligate the pentaform plexus separate from the testicular artery. And they'd go back and forth, because the argument was, well, you could cause arteriovenous fistula. And after a while, my resident mate went, excuse me, doesn't the testicular artery run in the middle of the pentaform plexus? How can you ligate it separately? At that point, everybody shut up, closed their books, got up and walked out. The resident trumped the faculty. That was pretty cool. So, scrotal neoplasia. And I know I'm going really fast because I'm trying to get you out on the Thanksgiving holidays because I'm here. Plus I'm losing my voice. Mast cell tumor is the most common of scrotal tumors, and it's a bad place to have mast cell. Mast cells in the genital area, whether it's on the prepuce or on the scrotum, it's bad news. Okay, they usually have spread already. Remember that they contain heparin and histamine, and platelet activating factor, and eosinophilic chemoattractive factor. So if you mess with these too much, you could have swelling, you could have bruising, you could have all kinds of unpleasant things happen. So be careful as you're manipulating these. When you go to do a fine needle aspirate on tumors, be gentle with them too. There's more mast cell out there than I ever realized there was. You know, I'd say at least 1/3 of the things we do affinase on are usually mast cells. Here it is, 50% of mast cell tumor in a dog are malignant, especially if preputial, inguinal, and perineal areas. And up to 80% of these guys will have ulcers, stomach ulcers. Okay? The next one is melanoma. They can be black, brown, or unpigmented, and they're more common in dogs than in cats. Local reoccurrence of distant mets, lymph nodes. Mast cell doesn't usually go to the lungs, but it'll go to the liver, it'll go to the spleen, it'll go to bone marrow, and it'll go to the lymph nodes. Testicular neoplasia, okay? One or more are found in 27% of dogs that need propsy, that aren't neutered. If they're neutered, they don't have testicles, okay? Top 3 to the right, meaning right here, are the most common. The rest are very rare, okay? Many old dogs have multiple tumors of one or both testicles. Usually benign, but in cryptorchid testicles, they're usually malignant. If they metastasize, they go to the lumbar lymph nodes or the inguinal, external iliac nodes. Visceral mets are uncommon. Okay? Extratesticular interstitial cells, or totally cell, have been known to occur in neutered dogs and cats. That means they came from the testicle and embedded before they were neutered. so early. If you wanna know what looks like what for necropsy, it's right here, but I don't tend to test on that because I don't care, I send them to the pathologist. If you wanna play the guessing game of what it is, then you can learn that stuff. Let's see, the important stuff here. Where is it? Signs, signs of hyperestrogenism, that's important for you to know, okay? Once you get this, even neutering it may not make it go away. Especially the thrombocytopenia and neutropenia, bone marrow suppression. Well, that's usually Seminoles, I believe. Did I say? Which one? No. Actually, I think it's Saratoga cells. Y'all know? Anybody know? Which one's estrogenism? You should know for Natalie. Just know that if you have a male dog that comes in and it's attracting male dogs, and it looks kind of like it's a female, acts like it's a female, you probably have hyperestrogenism going on. Okay, testicular torsion. These usually happen with cryptorchid testicles and can also have concurrent testicular neoplasia. All right? Vague signs of anorexia, vomiting, lethargy, signs of acute abdomen and shock. This is an emergency. We did have one of these in my residency as well. It was in a hunting dog. So it can result in death if it's not treated. Prostatic hyperplasia. Dogs will get this that aren't neutered because of the testosterone. 95% of intact male dogs by the age of 9 years old. I have a question about this. I'll give you a case. Dog comes in with hematuria, okay? I can't remember the other clinical signs I gave you, but he's an intact male. He's got hematuria. Think of this as one of the things that can cause that, especially if it's, I think above 5. They said 9, but I think above 5, because I've seen it 5, 6-year-old dogs. Eric picks at 5 or 6 years of age. That's why. Treatment, castration. You can give them the medicine for male humans for benign prostatic hyperplasia. It does work on dogs, but why? Just neuter them. Okay? Prostatic cysts. May be related to benign prostatic hyperplasia. Etiology, we really don't know. And we know it can increase risk with Saratoga cell tumors. So you think of a triad here.
Back to the prostatic hyperplasia, what happens to her after they've been neutered, if they were neutered at a later age? What would she be doing? Just giving them medication?
No, that's not gonna happen. Because if you have benign prostatic hyperplasia and you neuter them, within 3 weeks that thing shrunk. Right?
Well, I mean, what if they were neutered at a late age and then this occurred?
It's not gonna occur. It's not gonna occur after they're neutered. Now, if you have a neutered dog and you reach in there and you feel something, it's probably prostatic neoplasia. Prostatic neoplasia is higher risk in neutered dogs. I don't know why. I don't know why. It's kind of weird. But prostatic neoplasia is not very common. I think I've seen 2 in my entire life. So when you're talking about these diseases, prostatic cyst, testicular torsion, and cryptorchids all go together, okay? They're all related. And they usually have Saratoga cell tumor thrown in there too, okay? Now we have paraprostatic cysts that don't come from the prostatic, they're the site of it, they're rare, okay? Rarely they will communicate with the prostate. And they originate from the urus musculinus or embryonic structure derived from the mammalian duct system, okay? And then you can have parastatic cysts, okay? The problem with these things is they become large and they cause problems, right? And I think here's an example. We have Paraprostatic cyst causing urethral obstruction and urinary bladder rupture. Right there, boom. This is a Foley catheter in the bladder. These cysts sit there long enough, they can become infected, and you end up with an abscess. All right. And can y'all guess what bacteria usually comes out of those? E. coli, staph, and one more. Think of reproductive bacterial diseases of male dogs. Brucellosis. You got it. I'll let y'all just read most of that. So here we got a cyst, a cryptorchid testicle, a serotonin cell tumor. Here's the bladder, here's the cyst, and here's the testicle, cryptorchid testicle with the tumor. Well, I told you they all go together. You can do FNAs of the prostate. You can either go in this way, or you can actually come in just above the ischiatic table and hit it that way as well. Okay? Now, how do we fix these? We can omentalize them, so we can bring the omentum in here to this cyst. This is a paraprostatic cyst. We can put a mental attachment to that, and that'll help drain it, okay? You can also put drains in. Yes, it's exiting the abdominal wall, okay? And you can marsupialize them. That was mentioned today as well, with the goat, remember? So you make a hole in the body wall, open it up, and suture the cyst to the body wall. Neoplasia. Castration is considered to be a risk factor, particularly for prostatic transitional cell carcinoma. All right? But it's not very common. See here the percentages. Adenocarcinomas are more common in intact males, and they have Cox association. So you can use some of your anti-inflammatories to help treat these. Mainly, you think of prostate care. Okay? Prostatic carcinomas, they tend to be locally invasive. They can metastasize early to the lymph nodes, lung, and bone. Usually by the time you diagnose prostatic neoplasia, it's too late. Okay? Hypertrophic osteopathy. I know I haven't taught that to you in neuromuscular yet, but here's another disease you need to think about if you see HOP. That was on your test this morning, wasn't it? Did I get it right?
I think so. One of the few.
I think so. That was a long time ago. You can take out the prostate, but these guys are usually incontinent. Okay? So, tell their owners that, and usually there's metastatic disease at the time of diagnosis. So if they want you to do this, say, can you make him an outside dog? You can do a partial subtotal prostatectomy as well. And the chances of having urinary incontinence are not as great, but you still can have it. All right. Make sure you know what this disease is. I saw a thing on the internet. I can't remember if it was Facebook or just the internet, where somebody had claimed they found this dog by the side of the road and it had been brutally mangled and abused, and it had this condition. And everybody was like chiming in, and oh, they need to find the people who did this. They need to hang them from the high timbers. And then people that were vet techs and veterinarians started chiming in and saying, no, this is a congenital problem. That dog was born with that. Nobody did that to him. Okay? It's called hypospadias, I believe. I looked at it yesterday, in the dictionary, they give you the phonetic pronunciation. There's some speculation that Hitler had this. Yeah. So, what it is an abnormal development of the genital folds, okay? They fail to fuse, so everything comes together on the midline and fuses. And it can happen here. It's called glandular If it's along the shaft, it's called penile. If it's up here on the scrotum, it's called scrotal. If it's up here, perineal, or it can even occur at the anal place. Boston Terriers, poster child for this problem. I've been known to give you a picture and ask you what the diagnosis is. Persistent frenulum, okay? Again, my dogs, simple, just clamp it and cut it, all right? You can do a penile amputation or a subtotal penile amputation. I've actually had to do this twice. This is a complete penile amputation, and they ended up doing a urethrotomy for the urine. It's recommended you neuter these guys at the same time, because if you don't neuter them and they get excited, guess what? You're gonna have a lot of hemorrhage. The one dog I did it on, he had a mast cell tumor right up here on his prepuce. By the time I got wide margins, his prepuce didn't fit his penis, so I had to adjust his side. He was a working dog, and basically I told the handler he's turning in his rifle for a pistol. Oh, but he lived a long time after that. He was still at Fort Knox 5 years later. And then they retired him and he got the civil space couch. It's not really hard to do. You just put a tourniquet on here, you cut, and then you gotta spatulate the urethra and resuture it. You gotta adjust the prepuce to fit it, unless you're adjusting the penis to fit the prepuce like I was. Sometimes these guys are born with not enough covering, and these are the things you can do to help that. Basically, you're gonna bring the skin forward, that'll bring the prepuce forward. You can also do a purse string, or you can close this partially, okay? You gotta tighten up the preputial muscles as well. Okay. This condition's inability of the penis to protrude from the prepuce is rare, usually because the opening's too small. Simple, make the opening bigger, okay? Can also occur with neoplasia, trauma, cellulitis. What happens is you get urine pooling in the prepuce, and it's really irritating, okay? Treatment depends on the cause, can range from medical to preputial reconstruction or partial or subtotal penile amputation. These are the breeds that get it. Okay? Here's just some more pictures of reconstruction. I'm kind of flopping this bit. The paraphimosis, inability to retract the penis into the sheath. Okay? That can be associated with copulation, masturbation, trauma, hematomas, neoplasias, foreign bodies, hair. Hair getting wrapped around the penis is often a cause of this. So long haired coated dogs. Medical management, remove the constriction clean. Here again, you use saline or sugar to help reduce the edema and massage it back into where it needs to be. You can also use corticosteroids and diuretics as well. And if all else fails, you can operate on it. You can do a penile too. That's what they're showing here. They're cutting a little bit of the penile epithelium and suturing it to the inside of their prepuce. So you see stuff like this, trauma. Animal bites, hit by car, human attacks. Yes, human attacks. Can result in hematomas or penis fractures. This is a TBT, okay? But it also could be squamous cell or angiosarcoma or papilloma. TBTs are contagious and are spread by sexual contact. They could have them in their mouth. You could spread them with your equipment. They're wart-like and very friable. And that's it for that one. Y'all want a break or you want me to keep going? Okay. All right, oral cavity. Surgical diseases of the oral cavity in dog and cat are common, okay? I'm not going to talk about dental disease, that's Dr. Noriko did that. Clinical signs you can imagine, drooling, dysphagia, anorexia, bleeding, bad breath, nasal discharge, okay? Diagnostics, your eyes are going to be number one diagnostic tool in this case. You also do radiograph, CT, MRI, and various scoping exams. Remember the anatomy, because it's very vascular. But on that other hand, it's excellent healing because it's very vascular, okay? You want to use a traumatic technique because when you work in this area, you can cause edema, it may cause respiratory problems, okay? Tension-free closure are imperative here. So those are your big tidbits for that one. This is an AVLA question. Oral tumors in dogs, melanoma, squamous cell carcinoma, and fibrosarcoma. Okay, the top three. Rare to have metastases except for melanoma. What I was taught, if it crosses midline, it's a poor prognosis because it's really hard to get tumor-free margins when you remove it. Cats, squamous cell. Okay, squamous cell, squamous cell, squamous cell. Then you also have fibrosarcoma here. But squamous cell, think that 70% of cat oral tumors are squamous cell. Most of these have poor prognosis except for very Russell squamous cell and dental tumors. Which Dr. Noriko went over dental tumors, right? Epilus. Okay. Remember the blood supply. I'm not going to go through it. I put it here to remind you if you're going to operate on that area. We can remove parts of jaws, okay? And it's named according to what part you take. This has been a test question in the past, okay? So, this is a hemimandibulectomy. No, maxillectomy. Hemimaxillectomy. The lower jaw is mandibulectomy. Okay, so a hemi, a rostral, pre or bilateral rostral, okay, a caudal, and a central. Maxillectomy for the upper jaw, mandibulectomy for the lower. All right. I've been known to give you one of these pictures and ask you which one it is. Chilioplasty is closing the mouth on that side to keep the tongue from hanging out. Oh, here we go, mandibulectomy. Okay. See, they didn't alter his lip and his tongue hanging out. This one got his lip altered. It sounds pretty brutal, but actually there's high client satisfaction with mandibulectomies, okay? Especially if you get a cure or prolong their life for a significant amount of time. I've only done one of these, and it was in a dog that had a fractured jaw from being hit by a car. There was too many pieces to put back together. Other surgical procedures in the mouth is tonsillectomy. Squamous cell occurs in the tonsils, okay? Occasionally lymphosarcoma. Sometimes we have to operate on the tongue, either because of neoplasia or trauma, most of the time. You can remove a good bit of the tongue and they can still drink water very well and eat very well. I had one come in my straight facility, my first assignment in the Army, and I don't know what happened to his tongue, but from the base forward, it was all gone. But he could still drink. Other tongue procedures, lacerations, abscesses, pretty much that's about it. Oral nasal fistula, cleft palate. Okay, this is congenital disease. Right here. Communication between nasal and oral cavities, between the soft palate, hard palate, premaxilla, and or lip. The primary is incomplete closure of the lip and premaxilla. The secondary is hard palates, hard and soft palates. Okay, there might be a question about that. Congenital defects may be inherited, nutritional, hormonal, mechanical, or toxic. I've seen it when a dog, they didn't know the dog was pregnant, and I think she got prednisone, I think, and all the puppies had cleft palates. Yeah. Clinical signs: unable to nurse, early life death, rhinitis, respiratory infection, and middle ear disease. These are your poster children. So all your brachycephalics, and then throw in beagles, cocker spaniels, and dachshunds. I don't know. We'll figure that out. Siamese cats. Diagnosis, you pretty much figure that out by looking at them. Many are euthanized or dying before surgery could be performed. Older animals have less friable tissue that helps these sutures better. It's really hard to kind of operate on these little puppies. Prior to 6 weeks may hinder the bone development, okay? But your goal in surgery is to reconstruct the nasal floor. Neuter these guys in case it's congenital. So here's the cleft palate, secondary, right? Because in regards to the hard palate, the soft palate, you go trim these edges. What you try to do is flip these edges in and suture to each other to reconstruct the nasal cavity. So, and then you have to do tension relieving incisions to close the oral cavity. So that's what they're showing here. So you cut here, flip those edges in and suture them to each other, and then move the rest over. That's what it looks like in cross section.
When you say flip it in, you mean just pull them together, or?
You have to undermine it a little bit. So you've got nasal mucosa coming up and a hole going to oral mucosa, so you trim the oral mucosa, flip those down and suture to each other. Then you've got a gap up here, so you gotta make a tension relieving incision, undermine, pull it over, and suture that together, because you wanna close the hole. You leave your tension relieving incisions open to heal by second intention. They'll heal really fast. So that's not the hard part. To me, this part is the hard part. Trying to figure out all this mess and how to fix it. And I've looked at it multiple times and I just pray I never get one. Because it just, I'd have to see one, I guess. That's one of those, gotta see it to understand it. Okay, this is an acquired oral nasal fistula. Had from a nasty canine tooth. Here's another one probably from a foreign body, oral foreign body. These are difficult to deal with. Secondary to dental disease in older animals. Here you got rhinitis, mucopurulent nasal discharge. Diagnose it, you see it. Hello? Medical management, antibiotics until surgery or repair, and you gotta have prolonged fasting. And this is a diagram showing you how to do it. So they made an incision all the way around it, measured the bone to give you more mucosa to put towards each other and close. Okay, you may actually do a limited maxillectomy, that's what they're doing here. Here's some more. So those are interested, you can look at that. I'm not gonna ask you how to do this. It's more important to me that y'all know the diagnosis stuff. Okay, some more of them. And more. Okay, oral tumors, like I said, dogs, melanoma, squamous cell, fibrosarcoma, cat squamous and fibrous. I think we already gone through that. I didn't realize I had it in there twice. That's good, because this is a long one. Mucoceles. Okay? Salivary mucoceles. The cervical is A number 1. And this is the A number 1 breed that gets them. Okay? This one is a pharyngeal mucocele, and this is an emergency because it can block your ability to breathe. Alright? This one's called a ranula. It's underneath the tongue. How you can treat this one is marsupialize it. This one you want to poke a hole in it. This one you want to drain, and then you have to go get the salivary glands where it's coming from. So, what happens is saliva has leaked from the gland or the ducts. I already told you these. Zygomatic is rare. You've never seen one of those. Cause is rarely known, but they think blunt force trauma, foreign bodies, or salivus. And it goes, the salivary juice goes the path of least resistance. That helps you ID the affected gland or the site. Okay. Dogs greater than cats, males greater than females, any age. All breeds are susceptible, but for some reason German Shepherds and Poodles, Dachshunds, and Silky Terriers have a higher incidence. If you have a cervical one, put them in dorsal recumbency and see which side that mucocil gravitates to. That'll tell you the side. We used to talk about doing contrast studies, but it's usually difficult and it's really not worth hassling with, because what we do to treat it is complete excision of the gland of origin. Usually you're talking mandibular and sublingual glands, okay? This is a reminder, this is the parotid, this is the mandibular, and this is sublingual. So you go in at the bifurcation of the jugular vein, elevate it, and you go as far as you can forward to remove most, as much of the sublingual gland as possible. You can remove both sides, they still have enough salivary secretions to eat. And this is it's not near this pretty in epidural surgery, folks. I wish it was. This makes it look like it's really simple, it is not. Sometimes you gotta cut the digastric muscle to get some of the sublingual here. This is showing you ranula, or marsupialization of a ranula. Same thing as what I showed you earlier with the prostate. Okay. Oropharyngeal trauma, very common. Sticks and bite wounds. Yeah, I have some breeds here, but you know what? That could happen to any dog, especially retrievers. Okay. You're gonna have problems eating, you're gonna have pain, bloody saliva. They can get really sick too, depending on how long it's been there and how infected it is. You may have emphysema, air underneath the skin. Okay. Differentials, if you can figure that out. Here's emphysema in the tissues, so air is escaped all along here. And here's, I think, the soft palate, and there's a stick in there. Okay, ear surgery. We're gonna do this in the spring. This is a ZEP procedure. ZEP is the guy's name. This is for ear infections. This can help treat ear infections. This is before they get stenotic, okay? You have recurrent ear infections. You cut the skin, cut the cartilage till you get down to the horizontal canal, okay? And then you suture it open. So it just opens up the vertical ear canal. They still have to keep the ears clean, but this increases airflow. And that goes a long way in preventing chronic ear infections. I'd rather do that way before I do a total ear canal ablation. This is a vertical ear canal resection. The only time I can think of when you would want to do that is if you had a tumor up here, because it's better to have the canal open. All right. And this is a total ear canal ablation. You don't want to do these till they're really stenotic, because they will lose their hearing. Okay, it's very painful, causes deafness. You got to do a bulla osteotomy to get epithelium out of the bulla, or you're going to have chronic erupting abscesses. You can have Horner syndrome after this. That's not good. Sometimes it's permanent. It's not a fun procedure to do. I do not like doing this. I dodge them every chance I can. I'd rather do a TICA first. May not. Zap. This is TICA. Alright. The facial nerve paralysis 56. Cats. A quarter of them are permanent. And so you go in and do the bulla part. You can right straight from your TICA side, or you could do a ventral bulla osteotomy. Ear trauma, you're going to see this if you're in small animal practice. Big old hematoma, oral hematoma. Make an incision on the inside of the ear and clean it out, and then put all these mattress sutures, leave it open to heal by second intention. Bandage it up over the head, leave the opening free so you can clean it. Here's a dog that lost the tip of his ear. If you want to do cosmetic surgery on it, you can sew it to the skin of his neck, leave it there for 3 weeks, then cut it loose, recreate his ear. This is dealing with cartilage. Cartilage doesn't suture very well, so you want to suture the skin above and below it. You can try to go through this cartilage, but my experience, it just breaks. Yes?
What's your personal opinion on the button?
I do button. Well, it's, basically, it's still a mattress suture, you're just thinning it with the button. The button keeps your suture from cutting through the skin, basically. So people use, old-fashioned radiographic film, and we used to do them not digitally. They've used those. There's a commercial product that I really don't like. I use buttons. My experience is dogs will shake their head and it's flying across the room. So, some people inject those ears with steroids. They work for a guy I worked with in Virginia, but it never worked for me. They don't actually inject the ear, they inject the dog with steroids. He doesn't know. It always worked for him, it never worked for me, they figured. Probably because I was a surgeon. Squamous cell in cats, you'll need to take the whole ear off. And hope that you get margins, okay? Advise your owners of cats that have white on their heads not to let them bask in the sun. This is because of sun exposure. And oh, by the way, horses with white stripes down their nose part, they get sunburned and they get squamous cell. White dogs or light-colored skin, light-colored coat pattern dogs basking in the sun with their bellies can get squamous cell carcinoma in the skin. So sun damage is just as big a deal in animals as it is in us. All right. Cats, inflammatory polyps. Okay, these are usually young cats, pedunculated masses that arise in oral pharynx and the middle ear or external ear. We don't know why. They think it's congenital or inflammation related. Sometimes you gotta kind of look for these things. I've seen them up over behind the soft palate, up on the nasal side. You can see them in the ear sometimes. But they're really cool because all you gotta do is grab them and pull them. And usually you get them out and get a cure. Sometimes you do have to do a ZEP or a TICA or a bulliostomy. But most of the time, if you can see that mass, you grab it and pull it, it's safe. We'll see if it comes back. Usually they don't, or if they do, a second extraction will get it, okay? Some of them can get really bad. This is cat, see how its ears all blocked up from the inflammatory polyp. Prognosis is excellent with complete removal. Oh, yes. Okay, any questions? Okay, bandaging, really quick. Y'all actually like bandaging. You like this slide too. Bottoms up. It's Friday. But this is not what I mean. When you put on a bandage, you start from the toes and go up. That's what I mean. But this is good too. So, this is the big thing I want you to learn. External coaptation, that's bandaging, splints, cast. It can be a disaster if you compromise circulation. For example, I get really upset when I see this in the waiting room. You know, we told you to come back once a week. We told you to come back if it got wet. We told you to come back if it got dirty and stinky. Okay? That's what you can end up with. Yep. This was it, and they started cleaning it, and this is what they ended up with, and this is what they had to do, amputate. Because you can't fix this. Now, this is stupid. You can't fix stupid. Here's some more, okay? This is an old picture, but this is bad news. You see this on a bandage? It's brown, nasty, looks moist, probably stinks. Pressure sore, pressure sore, pressure sore. Here's another one. People say, I can't afford surgery. Well, you know what? You're going to come see me every week for this cast. And if I have something like this, you might end up spending just as much money with a cast as you do a plate. Or this. Okay, this is why I say bottoms up. They didn't include the foot. You got to include the foot and go up. You can't do a partial bandage. Here's another one. I can almost smell that from here. Now, these are the toenails. If you don't recognize what's going on, these are the toenails. It's all the way up here. Okay, so that's the biggest thing I want y'all to get from this presentation, right there. You can rock a leg with a bandage, or cast, or splint. Yes, ma'am? Yes. So, no coaptation device can be worn in complete comfort. Some minor licking and chewing can be expected. Maybe we need to put them on some drugs. But then if you have the drugs, they'll mask it. What I tell owners, I said, if they're going to be going along fine and they haven't really worried about it, and all of a sudden they're like, oh my God, I need to get this in. Something's going wrong. Okay? Sometimes I want to lick it and chew it from the get-go. Any signs of excessive discomfort, any changes in position or shape of the cast or the bandage, foul odors, unexplained soiling, okay, unexplained wetness, strike through, any sores that develop at the top, swelling of toes. We usually leave the two toenails, the two central toenails sticking out, and I tell owners to see how they're together right now. If they start to spread, and I spread them with my fingers, if they go like this, come in. It's an emergency. Inhabitus, depression, fever. Any excessive chewing of splint or cast. All that needs to be on discharge instructions, okay? When you have a fracture or a joint injury, and it's emergency, pay attention to the patient first before worrying about the fracture. Make sure they're breathing, control hemorrhage, treat shock, prevent infection, evaluate circulation and nerve function, then repair the wound. Because guess what? If their nerve function's gone, there's no sense in me putting a $1,600 plate on that fracture if their sciatic nerve has been torn up, or the brachial plexus has been avulsed. Okay? Then you're going to do the splinting and bandaging and managing pain. All right? Temporary pre-op treatment, Robert Jones. Full Robert Jones, not modified. Means big, bulky. I have a picture. Maybe a splint. If it's distal femur or humerus, probably no coaptation unless you use a spica. Don't worry, I got pictures. Okay? Then you have your definitive treatment. Sometimes we still coapt them even if we put a plate on them. Okay? At least for a couple of weeks. Robert Jones, big, bulky, comfortable, and conforming. Front and hind legs can be used with multiple limb injuries. Good thing about it, it immobilizes and reduces swelling and pain. This is an old picture. Here's a fracture. This is a non-displaced spiral fracture of the tibia. Can you guess why it's not displaced? Anybody? What do puppies have that adult dogs don't have? Well, they have growth plates, but what else do they have? No. But you're thinking soft tissue, so it's soft tissue. What coats the exterior of the bone? Periosteum. They have really thick, tough periosteums because that contributes to bone growth. So when you see a fracture like this, you can go, I bet you that's a puppy or a young, very young dog. Because the periosteum didn't get torn. And usually this is a low velocity fracture. So they didn't get hit by a car, they got foot stepped in a hole and they twisted and it snapped. Okay? Alright. Like I said, don't use Robert Jones with proximal, humeral, and femoral fractures. Acts as a fulcrum. When you do use a bandage, you want to coapple them in normal angulation, so a normal standing angle. Stirrups are usually essential. You got to be careful because they can wick water and urine. So here's your materials: vet wrap, stretch gauze, tape for stirrups, elasticone, and cotton. Either cast peg or roll cotton. Here they have the stirrups. You go from the bottom up. You don't come back down. So here they got a telfer pad over a wound, you got your tape band, tape stirrups, you put in your cotton, bottom up, in the gauze, it helps pack down the cotton. You can't put the cotton on too tight. Gauze, it's hard to put on too tight, but you definitely can put vet wrap on too tight, okay? Make sure the two middle toes are exposed, so we monitor for swelling. And it doesn't have to be actually pads, as long as you can see the nails, okay? If you've got pressure points like the carpal pad, dew claw, you might wanna pad those with a donut. Okay, modified Robert Jones, not as bulky as compared to the other one. All right, y'all got that? Two middle toes exposed. Okay, you can add a splint to these. You can add plaster to these to make a splint, or fiberglass, or there's the thermal labeled plastic. You could even use rolled up newspaper, okay, or magazine in the case of emergency, all right? Stirrups, it says craniocaudal, but if you've got wounds craniocaudal, put them on the sides, okay? There's no rule that says it has to be craniocaudal. Spike it goes over the shoulder or hip, okay? So here's your modified Robert Jones basically, and you add a splint, and then another roll of vet wrap or elasticon. And there's the stirrups going up against the splint. Okay? So people can do a V where the bend in the elbow is. Actually, I just pad mine really good up there. So here's the splint being put on, modified Robert Jones. You know, when I say normal angles, a little bit of bend in the carpus, and a little bit of outward bend, okay, about 15 degrees. This is more pictures. Like I said, it's a lot of slides, but it's mostly pictures. Really watch this. When I do a cast, this is a fiberglass casting, my padding comes all the way up to here. And usually I have a stockinette first, and I roll it down. So I'll show you, actually, let me show you that. So cast, synthetic, and plaster. Closed reduction. So you got the bones aligned manually, and then you put the cast on. You want to immobilize the joint above or below the fracture. You got to think about the cost and talk about it to the owner, because you need to see these guys all the time. Okay, so they're going to have a lot of visits into the clinic, and they may end up spending just as much. Okay, so here we have stockinette. First we have our stirrups, then we put the stockinette on, then we put the cast padding on, then we put the fiberglass on. Okay, wear gloves, because it's just like insulation, that fiberglass can get into your skin. Like I say, I bring my padding high enough up that once I get the fiberglass where I want it, I roll that padding down over the edge. So it pads that edge of that fiberglass really well. This is how they say, if you put them this way, you get them in the right angle. You know, I've seen them messed up either, both ways. Some people, they are down, that's the downside, will pull them up this way. You really just gotta watch that you get them in the right angle. Usually what I also will do is I will, before the animal, wake the animal up, is I will cut this cast down two sides. Usually from medial to lateral. Then I'll put my vet wrap on it. That way when they come in for a recheck, I don't have to knock them out and cut the cast off, it's already cut, it's 5-valve. I can take it off, I can put more padding on it, put it back on, maybe under light sedation, but I don't have to completely anesthetize it. It saves our money, and it saves me time, really. So this is doing it that way. I just say, just be careful you put them in the right angle. Okay, so this is fiberglass. Not too many people use plaster anymore. Oh, the guy who invented this stuff, by the way, is the guy that founded Lincoln Memorial University College of Veterinary Medicine. Yeah, he was a vet student in Georgia, inventing all this medical stuff, and he got rich off of that. He says, I make more money doing this than being a vet. So. Now he started at vet school. So there's cutting the cast or bivalving it. This is some old stuff. It was plaster that was made to be a little more lightweight. We have some of that in the hospital. So it's like plaster but lighter. Spica. Okay, you're gonna take your Robert Jones all the way up around the shoulder or the hip, depending on front or back leg, obviously. And you kind of do a figure eight around the leg. And you can carry it, you can actually take your splitting material up and over as well. Okay? So I've been known to give you a picture and ask you what type of bandage this is, because I think y'all should know this is a spica. Alright, Schroeder Thomas, grand rounds last week, remember? I hate this thing, okay? Contraindicated for proximal 1/3 of humerus and femur. Guess what that fracture was? A humeral fracture. I'm like, why did they do that? It can be disastrous. Okay? Hardly anybody does it anymore because it's hard to get right. Alright? Got to custom make them for every case. Need proper dimensions. Okay, if you see this in a practice and you're interviewing, really consider not working there. Okay? This is like a step of wood thing, and it has stepwise, kind of like a cake. You can make the circles different sizes. And then they bend it, that's the part that goes around the leg. Watch out for these guys. This is where that bar is going to sit. This is what they look like on the back leg. This is what they look like on the front legs, really for fractures below the stifle, below the elbow. Okay? What actually provides the traction on these things is the tape. Okay? The tape going this way and the tape coming down. I actually got a picture for that. Right here. Shows you where the traction's applied. Okay? I don't do these well, so I don't do these. Plus you can get, like I said, contraindicated for midship, femoral, or above, humeral fracture, same thing. That might be a good test question. Okay. Here's some examples. See, that thing made that fracture worse. The other problem is you can have, remember this, because I'll talk about it next year, okay? This is a quadriceps contraction. If you have a femoral fracture and you put them in a straight-legged splint, no matter what splint it is, you're going to get this, and you can't fix it. This is malpractice. So, standing leg orientation. This dog actually had surgery because that's the incision right here. Standing leg. Velcro sling. Okay, this dog's legs like this, right to his body. Velcro. V, right here. Everybody says, I can't get them straight. Velcro. V. Okay? This is an emer. We do this for craniodorsal hip luxations, which I'll teach y'all about next year. It's actually a figure eight going around the hock and the thigh, and then they bring it up over the back. You can also, I don't do these things, I don't do these very well, so I do what's called a 90-90 splint. It's the same, the leg is in the same configuration, but you just go around this way. And then with a little bit go into the back, so the foot goes to the back.
What's the trick to make them stay? Because at the practice I worked at last summer, it was like mission impossible for the dogs not to just like.
Taping it to their hair, using elastic condom. That's why I do a 90-90. You still have to tape it to their hair, but not as much. I'm not good at these. Oh, hit the wrong button. Okay. All right. Any questions? This is my Jack Russell. How many babies do I have? I have 2 daughters. I have 2 dogs. I have 3 cats, 2 rats.
Rats?
Yeah, 2 horses, 2 cows, 4 chickens, 2 ducks. The rats are not wild.